Good afternoon. I'll be talking about basic concepts of stroke and how to identify the stroke. A stroke is very common. So we are celebrating 29th October as a World Stroke Day. And this is celebrated to increase awareness among the general public population. And there are 3 R's in stroke. That is, first is recognize stroke early, reach hospital on time, and this will obviously result in reduced disability. तो फर्स्ट ऑफ ऑल व्हाट इज स्ट्रोक स्ट्रोक को हिंदी में लकवा या फिर पक्षाघात भी कहते हैं बाय डेफिनेशन स्ट्रोक इज अ क्लिनिकल सिंड्रोम कैरेक्टराइज्ड बाय रैपिडली डेवलपिंग clinical symptoms or signs of focal and at times global loss of cerebral function with symptoms lasting more than 24 hours or leading to death with no apparent cause other than that of a vascular origin. तो कोई भी अगर एक तरफ का हाथ काम करना बंद कर गया, एक तरफ का सुन पड़ गया हाथ अचानक से, इसको हम लकवा कहते हैं. TIA, what is TIA? TIA is actually a minor form of a stroke, a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without actual acute infarction. This implies the use of advanced imaging, which may include MRI diffusion weighted study and CT perfusion imaging. So TIA is actually a form of a minor stroke. Stroke and TIA is an emergency, and it is well said that time is brain. How time is brain? Because every minute, if stroke is untreated, the average patient loses about 1.9 million neurons, 13.8 billion synapses, and 12 kilometers of axonal fibers. So if each hour in which treatment fails to occur, the brain loses as many neurons as it does in almost 3.6 hours of normal aging. So 1 hour lost in a management of a stroke, that results in an aging of almost 3.6 years. So what are the types of stroke? We are having ischemic stroke, which is as infarct. Then we are having the ICH, which is a cerebral hemorrhage. Then we are having venous infarct, which includes CVT, that is a cerebral venous sinus thrombosis. And last is a subarachnoid. In ischemic stroke, we are actually having two components. First is a core and second is a penumbra. What we focus upon is actually salvaging the penumbra, and it is actually dependent upon the collateral flows. So our treatment is actually targeting to prevent the or to save the function of penumbra, in which the cells are actually structurally deformed, but functionally they are still working. So we want to target to salvage the penumbra. So in hemorrhagic stroke, we are having subarachnoid hemorrhage, subdural hemorrhage, epidural hemorrhage, and ICH. So this is one of the type of CVT stroke, that is cerebral venous thrombosis. Then on grossly, how to differentiate between the arterial from a venous stroke? Arterial stroke actually corresponds to a particular arterial territory. Venous stroke do not correspond to any arterial territory. And in arterial stroke, we are having a mass effect which is proportionate to the infarct size, but venous stroke, this is disproportionate to the infarct size. And hemorrhagic transformation is very much common in stroke. And pattern of involvement, cortical and subcortical involvement is common in stroke. And on the other hand, in arterial stroke, we are having the sparing of a cortex. So what are the risk factors of a stroke? We are having risk factors in the form of non-modifiable and modifiable. Non-modifiable means age, sex, and which is inevitable. Like everybody is supposed to age, genetics, this we cannot do anything. But there are certain modifiable risk factors which we can keep a check and we can control, like hypertension, smoking, diabetes, alcohol, heart disease, and dyslipidemia. This is all modifiable, which we can target and treat. How ischemic stroke occurs? First is that there is a narrowing of our blood vessels due to atherosclerosis. Then it could be cardioembolic, in which we are having the valvular heart disease and atrial fibrillation. Then we can have the prothrombotic states, genetic vasculopathy, and certain unknown mechanism in which it is known as the cryptogenic stroke. What is the classification? Etiology of ischemic stroke. We have a TOS classification, that is trial of ARG 10167, in which we are having the classification like large artery atherosclerosis, cardioembolism, small vessel disease, undetermined etiology, and the other determined etiology. So the most common one is large artery atherosclerosis. This we are having, this is just to depict how the large artery atherosclerosis goes on. This is a blood vessel in which the fat deposition occurs, and then there is a progressive deposition of fat which leads to narrowing of the vessels, and then ultimately maybe then there is an embolization of fat from this vessels to the other vessels, which results in artery to artery stroke, or if there is a complete occlusion of a vessel, then also it can lead to the stroke. So we need to identify the risk factors. Like if there is a AF, we need to do the ECG, and then after that we can give a definitive treatment for the AF, and we can prevent the cardiobolic strokes. Then we need to do CT imaging to look for the status of a carotid arteries, then echo to look for the patent foramen ovale, and also the this is the catheter intervention. What are the causes of non-traumatic ICH? In this, we are having a primary and a secondary cause. In primary, we are having the hypertension and cerebral amyloid angiopathy. In secondary causes of ICH, we are having coagulopathy, AV malformations, venous malformation, aneurysm, vasculitis, metastasis, CVT, and moya moya. So what are the symptoms of stroke? We need to identify the stroke. So सबसे पहले it can present like trouble walking. All of a sudden patient will have difficulty in walking. Then trouble seeing. All of a sudden patient will have vision loss. Then there may be weakness on the side of the body, and patient may present with trouble speaking. So what we need to remember is that B fast, which is actually a mnemonic for recognition of a stroke. B for balance difficulty. E for eyesight changes. Then F for face weakness. A for arm weakness. S for speech difficulty. And T for time, that you have to do a timely treatment. So whenever a stroke patient comes, triaging is most important. What we need is that we need to pre-notify the hospital of an incoming stroke so that the stroke team is activated there if at all there is a need. And we can have the rapid scanning imaging of patient, and we can have the rapid administration of the alteplase, which is the stroke or a clot-lysing agent. So what do we need to do in emergency? There are only certain things, that is like you need to look for a sugars and you need to look for a BP. This is what is the emergency evaluation and treatment. We can give the endothrombolytic agents, and if the patient is fulfilling the criteria for endovascular thrombectomy, then we can do endovascular thrombectomy. What we need to take care of is that patient need to be take care in the stroke care unit, and at the same time we need to look for complications which can arise from the stroke. So time is brain. Every hour is important. We have to be as fast as possible in the management of a stroke. Now, what is the urgent history and review we need to take in patient of a stroke? We need to look at a time of onset. We need to ask the patient last seen. Then what we need to ask is the symptoms at onset, if there is any worsening or improvement by the time the patient is presenting to the hospital. And we need to ask about the medical history of risk factors like hypertension, diabetes, smoking, alcohol intake, cardiac diseases, coronary artery disease, comorbid illness, and also of the medications history like antiplatelets, anticoagulants, premorbid functional status, like what was the MRS before presenting to the hospital, how was the patient functioning before patient had a stroke. Then in emergency, we need to do the urgent NIHS scoring of the patient. And then at the same time, we yes, assess ABC of the patient, that is airway breathing. Note for pulse, BP, and saturation. Immediate cannulation and blood sampling is important. Urgent random blood sugar, rapid INR for the patients with anticoagulation is important. And we need to, when we are doing all these investigations, at the same time, we need to do the CT of the patient in parallel. We do not need to wait for all the investigations, then proceed to the imaging. Everything need to be in parallel. Then what are the proven interventions for acute ischemic stroke? First is the use of thrombolysis intravenously within 4.5 hours, use of endovascular thrombectomy up to 6 hours, it is proven, but under certain spatial situations, can do under up to 24 hours. Then management of patients within a stroke unit. This is the emergency imaging, which we need to do is NCCT head and CT angiography. MRI when it is required, like in case of a wake-up stroke, we need to look for a diffusion pair mismatch, then we need to do MRI. Stroke is preventable. 80% of strokes are preventable. And what at most is important is that we need to look at the risk factors to make patients and patients' caregivers understand how important it is to control the risk factors like high blood pressure. We need to control. We have to avoid the unhealthy habits, avoid smoking, and you have to be active. Inactivity has to be. What are the principles of secondary prevention? Providing the patient optimum advice on the risk factors, medications. Have to tell about the importance of medication. So this is all the advice we need to give on the risk factors as the stroke is preventable. These are the medication with antihypertensives, antiplatelets, anticoagulants, lipid-lowering medications, statins, anti-diabetic, rate and rhythm control medications, specific medications for the cardiac and other comorbidities. So patient need to be understand that stroke is preventable, and these are the medications which can prevent the stroke, and a little bit of lifestyle changes can prevent the stroke. Stroke is having the highest global morbidity and mortality. So counseling of the patients is utmost important. Proper medication is utmost. Thank you.